Welcome to the much-awaited topic in EKG series, the ST segment. If you've spent literally any time looking at electrocardiograms in a clinical setting, you know that this tiny, seemingly simple portion of the tracing is a heavyweight champion when it comes to diagnosing critical cardiac events. In this explainer, we're going to completely decode the subtle and, sometimes not so subtle changes in this absolute lifesaver of a segment.
Here's our roadmap for today. First, we're defining the ST segment. Second, we'll cover acute STEMI and ischemia. Third, pericarditis and benign variants. Fourth, bundle branch blocks and LVH. And finally, number 5, aneurysms, brugada, and paced rhythms.
All right, let's jump right into section 1, defining the ST segment.
So what exactly is it? By definition, the ST segment is the flat isoelectric section of the ECG that sits right between the end of the S wave, which we call the J point, and the very beginning of the T wave. Electrically speaking, this crucial little line represents the interval between ventricular depolarization and ventricular repolarization. It's essentially that momentary pause when the ventricles are fully squeezed tightly together right before they begin to reset for the next beat.
Take a look at this visual right here. Notice exactly where that J point sits. It firmly anchors the start of the ST segment right before the T wave begins. When you are hunting for abnormalities on a tracing, that J point is your absolute North Star. You always have to find it first so you can determine if the ST segment that follows is inappropriately elevated above the baseline or depressed below it.
Now, the most important red alert cause of abnormality here is obviously acute myocardial infarction. But as you can see, there is actually a huge list of conditions that can cause ST segment elevation. We're talking coronary vasospasm, pericarditis, benign early repolarization, left bundle branch block, left ventricular hypertrophy, ventricular aneurysms, brugada syndrome, ventricular paced rhythms, raised ICP, and Takotsubo. And hey, while we focus a ton on elevation, ST depression is equally significant. You'll see ST depression with things like myocardial ischemia or STEMI as a reciprocal change in a STEMI or with a posterior MI. It's also caused by the digoxin effect, hypokalemia, supraventricular tachycardia, right bundle branch block, right ventricular hypertrophy, and even left bundle branch block and left ventricular hypertrophy. We're actually going to see some of these depression patterns pop up as reciprocal or discordant changes today, so keep those in the back of your mind.
Okay, moving on to section 2, acute STEMI and ischemia.
This is where it gets super interesting. An acute STEMI doesn't just have one single look. A lot of us are taught to look for that classic tombstone shape, right? But it can actually produce ST elevation with a concave, a convex, or even a completely obliquely straight morphology. You can see the sheer variety here across these examples. The unifying feature, the thing that ties them all together, is that the ST segment is being pulled upwards from that J point we identified earlier, loudly signaling acute myocardial injury.
To locate the exact area of the infarction, literally where the heart is crying out for oxygen, you systematically track that ST segment elevation and QA formation across specific contiguous leads. It's like a map. Elevation in V1 and V2 point straight to a septal issue. V3 and V4 show the anterior wall. Leads I, AVL, V5, and V6 reflect the lateral wall. And I2, I3, and AVF point directly to an inferior infarction. If you need to check on the right ventricle, you're looking at V1 and V4R. And for the posterior wall, you'll want to check leads V7 through V9. Honestly, memorizing these anatomic territories is absolutely non-negotiable.
And this beautifully illustrates a key dynamic, the concept of reciprocal changes. Because of how the heart physically sits in the chest as a 3D object, elevation in high lateral leads, like I and AVL, usually produces a reciprocal ST depression in the electrically opposite leads, like lead 3 seen right here. It's an electrical seesaw. When you see ST elevation paired with reciprocal depression elsewhere, your suspicion for a true acute occlusion should absolutely skyrocket.
But there is a massive curveball to watch out for. You might completely mistake coronary vasospasm, which is also known as Prinzmetal's angina, for an acute STEMI. Why? Because they both show localized ST elevation and reciprocal depression during an episode of chest pain. The crucial difference to remember is that vasospasm is transient. The EKG changes are completely reversible with vasodilators, and unlike an acute STEMI, there's usually no actual myocardial necrosis happening. But, and this is the tricky part, on a single static EKG tracing, it can be literally impossible to tell the two apart.
Which brings us to section 3, pericarditis and benign variants.
Notice how acute pericarditis presents.
Unlike the localized territorial changes of a STEMI we just talked about, pericarditis typically causes a widespread concave or saddleback ST segment elevation. You'll see this spread across multiple leads, typically I, 2, 3, AVF, AVL, and V2 through V6. Plus, look really closely at the PR segments here. They're depressed. That unique combination of widespread ST elevation and PR depression is a massive flashing clue that the actual lining of the heart is inflamed. You can also hunt for something called Spodek's sign. First described by David H. Spodek way back in 1974, this is a really distinctive downward sloping of the TP segment. That's the flat space between the T wave and the next P wave. It has a remarkably high specificity for acute pericarditis. Also, if you check leads AVR and V1 during pericarditis, you'll actually see reciprocal ST depression and PR elevation, perfectly mirroring the widespread changes happening everywhere else.
Another classic mimic is benign early repolarization, or BER for short. This is just a normal, benign variant that we commonly see in young, healthy patients. It causes mild ST elevation with tall T waves, mostly sitting in the precordial leads. What's super cool here is that subtle little notch right at the J point. See how it looks like a tiny hook? That's exactly why it's perfectly nicknamed the fish hook pattern. Also, keep in mind, these ST changes might look more prominent when the patient's heart rate is slower, and they can actually completely disappear if their heart rate speeds up.
Let's move to Section 4, Bundle Branch Blocks and LVH.
So in a left bundle branch block, the electrical signal is basically taking a massive detour, and that radically alters repolarization. Here we look for a rule called appropriate discordance. This just means the ST segment and the T wave should point in the exact opposite direction to the main vector of the QRS complex. So over the deep negative S waves in V1 through V3, you fully expect to see prominent ST elevation. And conversely, in the lateral leads with tall positive R waves, like I and AVL, you see ST depression and T wave inversion. It looks wild, but it's a completely expected, normal pattern for this type of block.
And guess what? Left ventricular hypertrophy, or LVH, mimics this exact same thing. The sheer mass of that thickened left ventricular muscle causes a very similar pattern of repolarization abnormalities. You get the exact same deep S waves with ST elevation in V1 to V3 and ST depression with T wave inversion in the lateral leads like V5 and V6. Recognizing this baseline distortion is absolutely crucial. It prevents you from accidentally misdiagnosing an anterior or lateral ischemic event when the heart is just hypertrophied.
And finally, Section 5, Aneurysms, Brugada, and Paste.
Take a close look at the ST elevation in leads V1 through V3 on this tracing. If a patient has had a previous anteroseptal myocardial infarction in the past, you might see this residual ST elevation sticking around long after the actual event, right alongside some very deep Q waves and inverted T waves. This specific pattern strongly suggests the presence of a left ventricular aneurysm. It indicates extensive myocardial damage and paradoxical movement of that left ventricular wall every time the heart beats. Basically, it looks exactly like an active, evolving heart attack, but it's actually just a very old scar. Now here is a deeply fascinating and genuinely scary inherited condition. Brugada syndrome is a genetic disease of the myocardial sodium channels, and it can lead to paroxysmal ventricular arrhythmias and sudden cardiac death, very often in young, otherwise healthy patients. It reveals itself on a standard resting EKG via the telltale Brugada sign. Look right at V1 and V2, you see this ST elevation paired with a partial right bundle branch block, creating this highly distinct, sweeping, coved morphology. It's a subtle pattern, but one you absolutely cannot afford to miss.
Finally, what happens when we introduce artificial hardware into the heart? Well, if you encounter an EKG from a patient with a right ventricular pacing wire, expect to see ST segment abnormalities that are completely identical to the ones we just saw in a left bundle branch block. Because the pacing wire starts that electrical wave over in the right ventricle, it travels slowly across to the left, which completely mimics an LBBB. Thus, you get that exact same appropriate discordance with the ST segment drifting completely opposite to those massive QRS complexes.
So, as we wrap up this explainer, I want you to consider this for a second. Even things occurring completely outside the heart, like raised intracranial pressure from a hemorrhage or a traumatic brain injury, can cause ST elevation or depression that perfectly simulates cardiac ischemia. It's wild, right? So the ultimate question you must constantly ask yourself when analyzing an EKG is this: are you looking at true, life-threatening myocardial necrosis or just a very, very clever ST mimic? Mastering the morphologies we discussed today is your absolute best defense against being fooled. Keep training your eyes, stay curious, and I'll catch you in the next explainer.